working to improve the health of communities of color in California. I've been the executive director there for 12 years. Do have my master's in public health as a health educator. I got it from UCLA, and sometimes I occasionally teach at San Francisco State Health Policy. So it's really nice to be back on campus and to see my colleagues and to see the upcoming health education field professionals. So CPEN was actually founded 20 years ago in the era of healthcare reform when President Clinton got up and held up a card and said everyone's going to have access to care. We know how that turned out. And so it's been really an exciting time for the organization to see something come to fruition. I don't know if people really fully understand the impact of the Affordable Care Act. It is something that a lot of presidents over the decades have tried to accomplish, and it really is, you know, in a person's lifetime does not get to be a part of this historic domestic expansion of a program. So it's been a lot of work, but it's also been really fun and exciting to be able to shape that in California. And I'm going to stop there. Okay. We'll go into more details.
Good afternoon or evening. My name is Alma Avila, and I'm the director of the Community Health Worker Program at City College San Francisco. And what we do there is we train frontline community health workers, people who are interested in obviously working with their community. It's a 17-unit program, soon to be 20-unit program. And actually, Mary Beth Love and then our chair, Terry Hall, now our vice chancellor, actually started the first community health worker program at City College. So it was created, I think, in 1994. And we've one of the few colleges that has continually had a community health worker program every year since then. Since that time, we've also added on 2 additional certificate programs, which is the Post-Prison Health Worker Certificate Program and the Youth Worker Certificate Program, and we call these our specialty tracks because all 3 share the core competency areas of the Community Health Worker Program. But then we provide additional training for people who want to work with the communities, those communities re-entering from incarceration, or people who want to work with youth, because we understand that it's not just about, you know, creating a program for youth, but actually incorporating youth into the decision-making process, into the development process, and helping to build leadership skills. So our certificate program is continually evolving as well, in that every year we ask our employers, because part of our program also has an internship component where our students are required to do a 128-hour internship where they have an opportunity to practice their core competencies within community agencies and health department clinics. And so it's been very good. It's been very successful. We've actually doubled our cohort last year with some funding that we'll talk about later with the San Francisco Department of Public Health. And it's one of the areas where the San Francisco Department of Public Health considers it, if they finish the certificate program, it fulfills so many months and years of I guess, employment requirements. So it fulfills like the requirements for the Health Worker 1 through the Health Worker 3 series. And so that's kind of what we do there. We train our students to prepare them for the workforce, as well as putting them on the track to more formal and further education. Turn it over.
Thank you. Good evening. Good to see you all. I'm Adam Burke. I'm a professor of health education in the Health Education Department, which HESA is nobly affiliated with, and thank you for putting this on. I really appreciate all the effort you put into this. Also the director of the Holistic Health Studies program here at San Francisco State. And the program's been around for about 30 years, was started by a fellow named George Araki, who's passed away, but a really wonderful fellow. He was a marine biologist here at San Francisco State, and then got an inspiration to do integrated studies types of courses in the health field, and this program emerged from that. And I took over, I've been here about 12 years at San Francisco, and took over as director about 6 years ago. And my background, I also have a master's, like Ellen, in public health from UCLA, so we must be doing something right at UCLA to have people contributing to causes like this. and went to a graduate school in social psychology at UC Santa Cruz after I had worked for a few years in public health. And during that time got very inspired with alternative medicine. Always had an interest in things alternative, but became particularly intrigued by Chinese medicine when I was finishing my PhD. So while I was finishing my doctorate, I was also studying Chinese medicine in San Francisco and abandoned academia. I became so excited about that that I left academia and fully immersed myself in Chinese medicine. Worked in Chinatown with a very remarkable old Chinese herbalist for about a year, and then went back to Santa Cruz and practiced there for quite a few years. And in some ways, Ellen was talking about a unique historic moment, and I think a lot of people, me included, in some ways, don't appreciate just the radical reform that this law implies. It's not obvious. What we see on the news is often the negative aspect of it, the difficulties with the rollout, but I'm sure it will come to pass, and the effect of this law is going to be really significant in the lives of millions of people in the United States. And in some ways it reminds me of the alternative health movement. Michael Goldstein from UCLA is a medical sociologist. He used to be down the hall from me, great guy. He actually wrote a book on traditional Chinese medicine and compared this to a social movement like the civil rights movement, like the women's movement, that this is a significant social change because people are basically taking healthcare in their own hands. A lot of alternative healthcare is self-care. And it's people who are disenfranchised or dissatisfied with the system. They want to be more involved. They want to have more responsibility. They want to take care of their own health and wellness. So that also is, in some ways, similarly somewhat invisible social movement that is impacting about 48% of adult Americans in the United States. So it is also a significant movement. There is some dovetail between ACA, the Affordable Care Act, and alternative health, which I'll talk about a little bit, but it's just exciting to be on the verge of this social change and to have a chance to talk with you tonight about it.
I think this is a very timely moment. The Affordable Care Act is on the front page of the paper just today, in the last couple of days, with regard to President Obama. So, Ellen, could you please just spend a minute doing, a thumbnail of what this is? I know that's really hard. And it is state by state, so give us some insights into how we're doing in California and why we should feel good about this as public health professionals. What is this going to mean for us?
So generally about you're not asking me about President Obama's
No.
decision today. So the Affordable Care Act, or some people know it as Obamacare, it used to be said derogatorily using that term, but I think the left has now embraced it as its own. So a lot of people are now calling it Obamacare generally. And really broad strokes, it does two or three main things. The first is it expands coverage, right? Health insurance through the exchange or the marketplaces, and the states had the option of doing their own or joining the federal exchange. California is doing its own, so that's what Covered California is our state's health insurance marketplace. It expands Medi-Cal, which is huge. So Medi-Cal was established in the 60s and for low income, but only certain low income. Children, elderly, disabled, parents of the children, and who was left out? Childless adults. So even if you're a low income, you're a childless adult, you could not qualify for the program. Come January 1st, almost 1.5 million people in California alone, will be eligible for this public program. So they're finally being brought in under the tent. So that's two big expansion issues. The second goal it does is it reforms the insurance market. So it's very wonky, but all you have to know is what they used to call the Wild Wild West. Health plans could do a lot of things. They could not even let you sign up, right? They could deny you because you had a pre-existing condition. They dropped you. So you could have paid for years and years and years, and all of a sudden you come down with a health condition. They go back, And they look at your application and they said, oh, your application was completed incorrectly. Your membership is no longer valid, and they dropped people. So lots of things happen, what we call the individual market. Right, so people who had to buy insurance on their own because they didn't get it through their employer, or they didn't qualify for public programs. So now there are a lot of rules in place to kind of clamp down on those bad practices by insurance companies. I'm sure you're going to hear more from the other panelists about a huge infusion of dollars for prevention. It made prevention services low cost. And then there are things around the edges, around quality, improving access. So we know that even though you don't have you have an insurance card, it doesn't necessarily mean you can see your doctor. So there's all these incentives for providers and other allied health professionals. So that's Cover ACA in broad strokes. And we go deeper later.
And how are we doing in California?
Oh, how are we doing? We're doing great in California. We're doing great in California. So actually, I have numbers. Cover California just released its numbers in conjunction with the feds, and so all the federal stuff has trumped what California has done. But Cover California, so our website is coveredca.com, and that is up and running. Okay, it's been up and running from day one. The biggest problem it has is that it doesn't have the provider directory on there. So if you have an existing provider and you want to make sure the health plan you're signing up with has that doctor, you have to call the health plans independently. Okay, so I have numbers. So almost 86,000 people were determined eligible for Cover California. 72,000 for Medi-Cal, the new program in January. There were over 97 completed applications, completely completed applications in California, and that translates to 177, so it's by household, so that translates to 177,000 people. Huge for California, and a great start. And we talk about this more, there's troops on the ground. There's the flyover marketing campaign. How many have seen the Cover California ads on TV? It's a welcome sign, right? Welcome to affordable cover. That's the one I've seen. So there's what do they call it? Those campaigns, the big mass, marketing campaigns, and then there are troops on the ground who are helping with outreach and enrollment. There's customer service reps you can call, the online application. So a lot of stuff going on to get people enrolled.
So there are two of our undergraduates, I wonder if them are here, who are employed by the CSU. You, okay, and who else? You. Would either of you like to just say a word about what you're doing? This is a grant given from a foundation to the CSU. And every department and School of Public Health in the CSU was asked for 2 students to come forward to work on our campus to help enroll our students and their families in Covered California. So let me just ask you to introduce yourself and share a little bit about what you're doing.
Hi, my name is Ori. I'm a coordinator for the Health Insurance Education Project. And we're working under this grant from Covered California to educate the CSU community. For us, it's the SFSU community about the Affordable Care Act, basically making sure that we know what it is, what it means for us, and that we, SFSU, we're a resource for not only students, but for our families, our friends, our neighbors, our communities. People who are affected by this law can come to SFSU and use it as a resource.
So within the next couple of months, we're becoming an official enrollment entity. So what we're doing as campus coordinators is we're going out around doing classroom presentations. We're also going to be having some Q&A forums the next coming months, just to get people informed about what this law does for you. What are the benefits for you? How can we help you get enrolled? And just basically trying to get the information out there so that everyone is aware of what kind of resources they do have available to them. So that's basically our job.
Thank you so much. So there is much pain and suffering in our country with people who do not have health coverage. It is the #1 source of bankruptcy in the nation, and that's just the beginning of the story. Much emotional pain and difficulty for individuals and families. So, Adam and or Alma, would you like to expand a little bit more on how you see the Affordable Care Act having an impact on community health workers and frontline health workers, or with prevention and particularly alternative methods?
So the Affordable Care Act, I think it's going to be really beneficial in the work that we do also, because it's going to cover at least what they call the 10 essential benefits. So things like screening, preventative services, immunization, mammography, colonoscopy, emergency care, hospitalization, things like that, that sometimes, like what Mary Beth Love said, is like this is what puts you into bankruptcy. So by helping the community health workers and with additional training where they can be able to refer and help them with either eligibility or referrals to enrollment, they will be able to kind of reduce health disparities by eliminating some of those barriers, such as like access to health care. So that's going to be one important role that the community health workers will continue. They do some of that now, but now with this opportunity to have access to health care, they will be able to do additional enrollment. And for people who usually don't have these services, will now be able to, minimize some of the problems that they had, including things like for transportation, and in a culturally appropriate way, they'll be able to really get them to participate a little bit more and feel more comfortable. I think other things that's going to be important, I think other things that for the community health worker is going to be important. And then I want to go back a little bit and say, as far as like we might be getting a little bit ahead of it, but
That's okay, just go.
So for the patient navigator is one of the, we see that in the Affordable Care Act, there's putting a lot of funding under training for patient navigators that are supposed to help with enrollment and eligibility, helping them. For the community health worker, they've had a lot of different types of titles, and I think in the past, patient navigators was a role that is a little bit differently defined than the ACA defines it, or the Affordable Care Act, because under the Affordable Care Act, the patient navigator is a lot more limited or more narrow in the roles that they have, whereas in the past, patient navigators or community health workers or lay health workers did a lot more. And so they will continue to do this. So I think in this new arena of the Affordable Care Act, community health workers are just going to have an expanded role, where they will now have opportunities to enroll communities that traditionally haven't been able to be enrolled. So those are some of the things. And then I will continue. So once you go on.
If you're on a roll, go ahead.
No, go ahead.
Okay.
But I will continue talking.
All right. We'll take turns. So probably a little background is helpful. In the United States, I think sometimes there's a misunderstanding of the size, really, of the alternative healthcare movement in terms of the provider side of it, in terms of who's providing actual care, licensed providers of alternative medicine. For example, I'm a licensed acupuncturist. California has the most acupuncturists in the United States. Coastal cities is where acupuncturists tend to reside, and New York, Boston, San Francisco, Los Angeles. In the United States, there is probably today 25,000 licensed acupuncturists. In the United States, 25,000. In the United States, there's almost 3 million nurses. There's 500,000 MDs. So when you just look at that comparatively, there's, in terms of naturopathic physicians, there's a couple thousand naturopathic physicians in the United States. So proportionally, obviously, these are very small in comparison, and in terms of thinking of alternative providers as really making an impact in the Affordable Care Act in terms of provision of care, I don't see that as being a significant contributor because they're such a small part of the labor pool. However, they have worked very ardently, just like every other profession, to make sure that they're included in this because they anticipate they will grow, especially if there is provision for their care in the Act in terms of getting reimbursed. That's how everybody stays alive, you get paid. So they've worked with people in the House and Senate who are supportive, like from Iowa, Tom Harkin, thank you, geez. And our own Nancy Pelosi has been a contributor, Belkowski, Barbara Belkowski, gosh, some other names will come to me eventually, but there have been a number of folks who have been very involved, very supportive. Tom Harkin, as an example, his wife, I believe, died from cancer. Many people who have very serious chronic diseases become big consumers of CAM because they're trying to stay alive, they're trying to deal with enhancing their immune system, they're trying to deal with the toxicity of the treatments they're getting from conventional care, they're just trying to deal with their own well-being and happiness. So the point is that I don't think that the provider side of the holistic health field is actually going to be a major player in this, even though they're working to make sure that they're in the game. That there's a non-discriminatory aspect to reimbursement that's very important to them, and they're working on that. But I think what's more important, as Mary Beth suggested, is the whole inclusion and endorsement of wellness, health promotion, public health. I think that's a very significant part of this new bill that will, if it's implemented successfully, have a major impact on the lives of everybody in the United States. The consistent killers of heart disease, cancer, chronic obstructive pulmonary disease, all of these kinds of diseases have lifestyle components to them. Exercise, nutritional status, smoking, alcohol use, stress, all of these are major contributors to all of these diseases. And our current model of healthcare is reimbursement for treatment for sickness, essentially. You do not get reimbursed if you're helping people manage their stress and optimize their wellness. I mean, who gets paid for that? The other thing that happened that's part of this bill, which was just announced in the past 2 days by Kathleen Sebelius, which is radical, is parity for mental illness. That is so important. If you've ever lived or known or have friends who are dealing with serious chronic depression, who are dealing with some other kinds of significant mental illness, that is such a gift to people to know that their care will be provided to them in the long term. So that really, to me, is the exciting part of this from a holistic perspective, is just this emphasis on wellness. And as one last example, and I'll pass the baton here, but I'm also very excited about certain things, certain sections of the law that have been supported. One of them was supported very ardently by the President himself, which is the individual wellness plans. And that is very significant. It really is focusing on high-risk populations, dealing with some of these behaviors like smoking, drinking, nutritional status, and all that, and working with high-risk groups and basically helping individuals get individualized wellness plans so they know how to begin to implement change in their life, which, as I'm sure all of us know, if we've tried to change anything, which we all have, is not easy. So this is very exciting news, actually.
And I would just add also within, like, so for community health workers, that is exciting because one of the roles that they will be taking on is really looking disease, self-management around chronic conditions, so they will be able to help the populations develop these action plans, and that is a big goal. There is funding in the ACA that's also set up to looking at funding community-based organizations and public health departments so that you look at prevention around whole communities. And the areas that they're really focusing on as well are areas that are chronic conditions that take up about 75% of the healthcare. So things like diabetes, cancer, heart disease that are big contributors, and the major they take up the major amounts of our healthcare in the United States. So community health workers are going to be charged with really looking to helping train on how to do self-care and self-management and developing your own action plan. So looking at both at a community base and an individual base. You still need to take personal accountability, but this now allows us to really look at more of a population-based approach as opposed to that individual. So that is exciting. It's really looking at prevention, so looking at preventing the disease rather than just treating it. Okay.
So I always feel like I need to begin this by what I'm about to say, by really grounding myself and you and myself as a patriot in this country, and also telling you that we are being fed a really big lie. And the really big lie is, earlier this year, the World Health Organization put out a report on the health in the United States, which basically shocked the world. Let me repeat that. It basically shocked, certainly, everybody in this country. We fare poorly across every indicator of health when compared to every other developed nation on the planet. We rank very badly. Now that is in the face of the fact that we spend more money than anybody else. So if you think what these experts are saying to you is a giveaway program, is welfare, is something that we shouldn't be doing for our citizens, that's part of a hegemony that is really not in the interest of the public's health. It's in the interest of greed and money, but it is not in the interest of public health. And it is only through events like this, thank you very much, where we really come together and say, we know better. We know better, and as a patriot, as people who want our tax dollars to be spent on our citizens, on the health of our citizens, on the education of our citizens, it is imperative that you and me and all of us become health educators right now, today, with everybody we talk to about how important this bill is and how we need to get behind it and lean in. The other thing that I just want to point out is, anyone notice anything? What do we know? Who's heard of the ecological model? Now let's look at these panelists up here. You notice anything about these panelists? What's Ellen do? Policy. What does Alma do? Community. What's Adam been talking about? Self-care. So without even knowing it, we have a perfect model of the f-stops on the camera that you hear about over and over again. Meaning that if we're going to be effective, we need to be intervening at every level. The individual level, the community level, and the policy level. And tonight we're talking about the big lever, which is the law. Because the law is the top that trickles down all the way down and makes all this stuff happen, and we don't have to fight anymore. Because it's the law. We need more of those in the interest of our people. But let me come back to the panel and Ellen, ask you to say a little bit more about how, as public health professionals, the current and future workforce that you see in front of you is going to see changes in their work in public health as a result of this law?
Okay, that was not one of the questions that I was given by the but that's okay. So, you know, I started my health education career in a community health center where we saw a lot of Medi-Cal patients and the uninsured. So the first thing is that our uninsured population is going to shrink. That's going to be great. But California is a huge state, have a lot of people who may be eligible for insurance but are not going to apply and enroll. And then we have a lot of undocumented immigrants who've been left out, yet again, of the healthcare system. And so the estimates are about we're still going to have 3 to 4 million Californians who will be uninsured. So our safety net, our public health programs, public health clinics, and our community clinics, our public hospitals will still be really, really critical to maintain that capacity. But I actually think, given that more people will have increased coverage, that I think the next wave is going to be improving the quality of the care that we all get. So what are we getting for the money that the federal government and our businesses and our individuals pay into insurance? And driving down healthcare costs generally, right? So it's still over $2 trillion is spent, about 17% of the gross domestic product in the United States. We don't get very good health outcomes for all that money. And it just keeps going up higher than the rate of inflation. And we all cannot keep up with it. We just don't have the resources to keep up with it. So I think those are the two big areas. Now that we've got the big coverage expansions under the way, there's still going to be more coverage to do, the 3 to 4 remaining uninsured. But I do think now it's how we move our healthcare system for sick care to well care, quality. There's these things called never events that happen in the hospital, where people go in the hospital and they get sicker because something happens to them that shouldn't happen. And as part of the ACA, it's like, we're not paying for that anymore. We're like, you don't get money for that. So there are all these things that happen within our healthcare system that I think more and more people are going to take a closer look at and be like, that's not going to be acceptable. So I think those are the coming trends.
So Adam, can you speak a little bit more about how the ACA will help the individual take better care, and will there be more access to self-care methods that are reimbursed, even the kinds of things like the wellness plan? Can you help us understand that more deeply?
Sure. I actually have a question for Ellen too, though.
Yes, please.
May I also?
Yes,
okay. Because I'm curious. You remember a presidential election recently with one Mitt Romney, whose health care plan we're now using, known as Obamacare. And in those days, during the debate, Obama made a point that it was Mitt Romney's plan in some ways that we were using. Interestingly, when you look at health care in Massachusetts, where Romney was the governor, radical change in provision of care for the uninsured. However, and this is an interesting point, they have one of the highest utilization rates of emergency room care in the United States. So there is an issue, and I was just reading another article that spoke to the same point, and then I'll answer your question, Mary Beth, but I was just curious what Ellen had to say about this, that a study I was reading, I think it was published in Medical Care recently, and it was looking at several years of data, several waves of data, that was anticipating that even though ACA is now taking care of a larger Medicaid population, for example, Medicare population, and also uninsured and all that, that it doesn't necessarily mean that providers are going to provide care for essentially the indigent populations who now have insurance. They don't want those people because they don't get a good reimbursement rate on them, and they're even more disinclined to now care for the uninsured because there's no reimbursement for them. So I was just wondering if you had any thoughts about that before I answer Mary Beth's question.
So the ER utilization, I think there's a myth that, I mean, the uninsured do use the ER because that's, in clinics. But many studies show that actually people sitting in the ER are the insured because you call up to try to get an appointment and you can't actually get an appointment. So this whole thing about even though you have an insurance card doesn't mean you're going to get the care. I don't know if there's this law in Massachusetts, but in California, we have two regulatory agencies that govern our health plans. They have to prove that they have an adequate network of providers to see the health plan members, and we have a timely access to care law, that as soon as that person calls up to get an urgent care appointment, a preventive care appointment, the time starts, and they have so many days to get them into care. So hopefully that will help. In terms of reimbursement, California has the lowest Medicaid, Medi-Cal, provider reimbursement rates in the country. This year, which it hasn't been implemented yet, so it's going to have to be retroactive, 2013 and 2014, the federal government's going to pay Medicaid providers up to Medicare rates for 2 years to incentivize them to take Medi-Cal providers. So we'll see if that works. But there are provider access provisions in the bill that try to get at that issue.
Just want me to, okay. Thank you. That's helpful, though. Thank you. So in terms of your role as health educators of the future, or whatever health fields you may be going into, I would say that a huge part of what you do, whatever your title is, and Alma might want to speak to this, is educating people. One of the reasons, just responding to Ellen's response, just thinking about that, one of the reasons that people with insurance are going to the emergency room, part of it is accessibility. They might not have care in their neighborhood. The other part is they just might not know where to go. That's part of education, is just informing people what the services are, what they might want to use for their particular needs. So that's more on the clinical side of education, but I think that's also a hugely important part of this. On the preventative side, Mary Beth's question, one of the other exciting things from, again, the holistic health worldview, one of the other exciting things about the Affordable Care Act was the constitution of the National Prevention Council, which has a much longer name than that I always forget. It's National Prevention, Public Health, and Integrative something. It's a huge name. So they call it the National Prevention Council. And the Surgeon General is the chair of that, and the secretaries of all the departments, Department of Defense, Department of Labor, Catherine Sebelius, they're all on this as the directing body. And then there is an advisory council to the council. One of my colleagues who's at the University of Vermont Medical School, whose research is in massage, she is on the advisory council to the council. So they have a lot of alternatively oriented people as advisors around the advisory council. And I think that particular group has a very strong preventative orientation. They think in terms of Healthy People 2020, for example. So they're looking at issues of disparities, health inequity and disparity, individual empowerment, safe and healthy communities, and they have a fourth strategic plan goal that they're working on. But that concept of prevention and wellness is just fundamentally embedded in the Affordable Care Act. It's a central component of it, a very important component of it. And really, in some ways, as Ellen was saying and alluding to, the fact that part of this act, which again is not obvious, everything you see on the news is really about providing care to the uninsured. But a big part of it really is about changing the quality of care in the United States. The Institute of Medicine had a really important document that came out a few years ago, which really talked to the issue of non-standardized quality, non-standardized service, and opportunities for preventative care in the United States. that are really being missed. So there's a lot of room for improvement, and our standard nationally, given the fact that we are the highest per capita healthcare expenditure, really speaks to the fact that we're doing something wrong. Cuba, which I always love to use as an example, for whatever reason, Cuba's a very cool place in a lot of ways. Cuba is dirt poor because of the embargo, which has been imposed on Cuba forever to punish them. Cuba has one of the best infant mortality rates in the world, and it's not because they're spending a whole lot of money, it's because they have community. It's because you've got a home health worker who goes to the mom's house every now and then and checks on her eating, on her blood pressure, things like that. It's very low tech. They don't have money. I was in Russia, teaching in Russia about 15 years ago, and I got sick because I ate some strange, nondescript food product. And you could not find Western medicine. I was being treated with herbs, I was being treated with charcoal powder, I was being treated with biogenic healing. They didn't have medicine because the ruble was worthless. You know, if you don't have cash, you can't buy Western pharmaceuticals. Even if they're being from, you know, coming from India or somewhere, and if they're generic, it's still, you still need money to buy these things. So the point is, you don't necessarily need money and technology to be healthy. You need to get the toxicity out of the environment. You need to eat simply and better. You need to drink water. You need to breathe clean air, which means you need to be an advocate for your health, because there are other parties who are polluting, who are laying waste to the land, and I mean, it is community and individual together that really contributes to health and wellness for individual and community. So, I guess I'm on a soapbox, I'm ranting, I'll stop. But the point is, thank you for agreeing with me. Jeez, you can tell we work together, can't you? But it's just an exciting piece that the self-care and wellness is foremost. And even Obama himself pushing the wellness plans just says, and his wife, Michelle, being such an advocate for kids' health. I mean, they walk their talk. They believe it. They get it. This is really important for the disenfranchised in the community who, and again, I'll stop, but 30 seconds, I'm doing an article right now on who does not use alternative medicine. One of the biggest predictors of who does not use alternative medicine is not being educated, not having information. If you do not have information, you cannot make informed choices about your health, period. And that's just the canary in the coal mine is people are not using acupuncture, not using herbs, not because they can't afford it, it's because they don't know about it, literally. So that's a big part of health education at the very fundamental level, is letting people know what's out there, what your rights are, what you should do to take care of yourself, and to become an advocate for yourself.
So let's ask one final question, and then I'm going to open the floor to you to ask the panelists some questions, or to bring up a discussion or add your own voice to the discussion. Alma, what really excites you? You are very close to community health and to community, and you work with people, frontline workers, which are the liaisons between the community and the healthcare system. When you think of the Affordable Care Act, what is it that you feel excited about that it will provide communities and provide the people, you've said a little about this, but provide the people who are close to and advocates for the community in the healthcare system? What makes you excited about this?
Well, I'm excited for a lot of reasons. One, because the people that come into our programs are people that really do care about their communities. They want to give back. At some point, they found themselves without health insurance. They found themselves in some kind of domestic violence situation where there was nobody to help them, and somebody that knew, I know somebody who can get you some services here. I know a safe house where I can help you. It's like the people who know, who are part of that community. So with ACA, or the Affordable Care Act, that will continue, but I think they're going to have more opportunity. And as far as for you in the field of public health, I think there is going to be a lot of growth. I think there's going to be a lot of growth around public education. We're going to be looking at, rather than individuals, we're going to be looking at how can whole communities be healthy, right? So you will be tasked with making sure that you can outreach to them, you can speak their language, you can be able to create the materials and the education in a way that they can understand, because literacy is still going to be an issue for many. There are going to be those marginalized populations that are not even considered, and that will be your job to outreach to them. I mean, it excites me to know that, one of the things that we're really starting to change our curriculum around is really looking at it as a patient-centered, patient-centered care. What is it? Letting them become really more active in their own health care. How do you manage your own chronic condition? How do you ensure that you're not going to get it? And, it's like in probably some public health class you learn about, it's like you can take a person, you can take a person to the water and they fish, and you give them the fish and they eat for the day, but if you teach them how to fish, they eat for life. And so that's your role, is to help them be able to be self-sustainable. They can manage themselves, they can navigate systems. I mean, it's going to be very complicated, but I think it's important for us to understand that everybody has the capability of learning how to do things for themselves. They just need a little encouragement. So focusing under, how to motivate them. We do a lot of motivational interviewing. We will focus on how to incorporate them into their own action plans and let them decide, where they start. So in our curriculum, we're always looking at where else are there opportunities for people to work. Right now, we're working a lot with people who are coming out of the prison system. And we look at life experience, because everybody does have that life experience. So we say, how do you integrate your own life experience into some sort of a skill so you can use that to help others? And so all of these things we are constantly integrating into our curriculum. We look at our employers every year and they tell us what are the new trends, what do they need, and some things that they tell us is we do need to continue to understand how to research certain health issues, how to do we do our own health education? How do we facilitate groups? How do we get that information out to them in a way that they can understand? Because it is important, and as we were saying, disease management, chronic conditions are, the bulk of what takes up of our healthcare dollars, and we need to, if we can start to prevent. So looking at public campaigns, how can you participate in policy development? In all of our programming, we look at policy, because you cannot, as Ellen has been talking about, policy is very important in healthcare, and you can't take it out. It has to be part of it. So our community health workers learn about, participatory active research. How do I research? How do I talk to the community? How do I understand what they need? So I don't go in and tell them this is what you need, but rather they tell me, and then we work together so we build and help to the community empower themselves. So all of this is going to, ACA is going to provide opportunities for that. Through one of the funding mechanisms through ACA, they have the community transformation grants, where they'll be giving funding so that you look at community-based prevention. And I think community health workers are going to be important in that aspect. I think there's 4 sections to that. One of the other sections is looking at the clinics in health departments. And one of the things we're doing in one of our grants is we're integrating community health workers into the health department clinics so that they can then do the referrals to other community-based organizations. So really trying to make it seamless, where the community health workers helping them to get into the clinics, helping them with enrollment, and helping them with other services. So maybe it is meant, it's not just, diabetes care that they need, but maybe they also need some help with housing or education or employment. And so we're looking at the whole aspect, which brings into kind of like the whole holistic approach. We're also looking at primary care models, or where the community health worker is part of the primary care team. So as far as for future education, I think you all will maybe need to understand a little bit more about some clinical knowledge around the training. We find that a lot of our employers are telling us that the students need to know something around chronic care management. And so that will be important. I think other areas that are going to be important is health promotion. tobacco is the #1 risk factor for a lot of the health problems that we see, and so there's going to be more campaigns, and policy will be important in that as well. And so there will be health in every aspect of policy from here on, is what I see. So I think the growth is very great, and there is a lot of potential for the work that we do, both at the entry level and at higher levels. And I tell our students that they need to not only get the training skills, but they need to be on a path of higher education, because they need to be in positions where they are making the programs, where they are at the level of the decision making. With everybody else, they need to be a player, they need to be a stakeholder, and so they need to be involved in all aspects. So I think, the field is very wide, from community organizing to clinic work to research, because there's going to be a need to do some needs assessment around the quality of care that we're getting within ACA, and so there's going to be opportunities for people to do that kind of work as well. Research, community level efforts, even grant management. There's going to be some funding sources around, so people who want to understand about how to write grants and how to assist community-based organizations writing grants. There's a lot of arenas that everybody can focus on, but I think it's really enormous, the growth or the potential that it currently exists and will continue to exist.
Well, thank you. And if there's anything that we, fully understand as your faculty, is that you really bring a lot of expertise on this matter yourself. And so let me open the floor to you to either ask a question or state your perspective on the American Care, thank you, American Care Act, the Affordable Care Act, and share with the group. And the first hand I see is back here. Can you speak loud, or you want to take my microphone? I think you should take my microphone.
Can y'all hear me?
Can you hear her?
Can't see you, but we can hear you.
Here, come to.
Where?
Come to. Thank you.
Where are the providers going to come from if we're increasing? Because I know they're expanding rates and reimbursement, whatever, to Medicare and providers and stuff like that, but I don't see how there's enough physicians to provide for everyone that's going to be able to get in ASAP.
Okay, so Jessica, thank you very much. Jose Ramon's going to take this.
Do you want to answer this?
You go.
It's actually been an ongoing issue. People have brought that issue up, and one is we are unsure of the pent-up demand, right? We don't know, because they've been uninsured, but they might have been getting care at a community clinic, at a public health. So it's unclear how much demand that there's going to be. And in terms of, I think there won't be enough providers, and that, again, the health plans are going to have to do a lot of work to show provider network adequacy, so there's going to have to, contract with them. But there's also going to need to be an effort to expand our provider base, and who can provide what types of services. So the wonky term is scope of practice, and making sure our allied health professionals have a stronger, larger role in that.
I think that one of the criticisms of the Affordable Care Act was that there were no good provisions for expanding the size of the workforce. Of the 35 to 40 million people that will probably get some form of coverage, a high percentage of them do not speak English as a first language. So it's not only the number of people that will need to provide lots of different services, but can they actually talk about access? Language is critical in terms of access. Mental health. If you don't speak the language of the person that is seeking mental health services, the services are useless. So it's an issue.
There definitely won't be enough mental health providers.
Actually, one other aspect of that, there was an article in Health Affairs just this month by, she's from the UCSF Center for Health Professions. She's a lawyer. I forget her name at the moment. But basically, their piece was on the scope of practice for nurses. Again, there's about 500,000. Catherine Dower, yes, thank you. Catherine, quite bright, good writer. And there's, again, about 3 million nurses, about 700,000 LPNs, so there's a large pool of potential providers there, but by virtue of their scope of practice, which is regulated by the states, they're quite hamstrung in terms of the kind of provision they can carry. There have been studies looking at how nurses in like storefront clinics can actually provide cheaper care than equivalent kinds of services MD provided, and if it's basic preventative care or basic kinds of clinical services. It's not rocket science particularly, so a lot of people have the potential to do that, and it would be much more cost effective to have nurses versus MDs provide that. It's one of the reasons, for example, that acupuncturists are treating pain, and Kaiser, acupuncturists are cheaper than MDs for treating pain, for example, but it's still cheaper to use a pain derm, a pain patch for somebody. So they're disinclined to use acupuncture. They could hire 10 times as many, but they basically hire them for marketing probably more than for patient care. But the point is that there are potentially other pools of providers. It's just a function of how the law addresses scope and sees them.
Yes.
Well, I've just been keeping track on on the nurse practitioner's role. I'm here in my last year at SF in the nursing program. I'm really excited for the future of nurse practitioners, because they're smaller in numbers, but it's now accessible for anyone with their undergraduate degree in whatever topic to go and get their master's entry level in nursing. So I think we're at a cutting edge moment in that timeline. And I know that AMA is having some reservations about allowing nurses with their master's level to practice. I think it depends on degree of experience, and the new doctorate of nurse practice is going to be a great degree, a terminal and degree for nurses who maybe don't want to go into education and want to stay in the clinic, but want to be on the same levels as physicians. So
Wonderful, thank you for that comment.
Thank you. This is maybe a bit of a rhetorical question, but because Ellen, you brought up, we don't know what the pent-up demand is going to be. I think about the decades, if not centuries, of some of the deferred mental health care that we have in this country. And I'm a little concerned, if we're not on the proactive end of this, that this could actually lead to a fast track to subsidize big pharma and stay stuck in a downstream approach to public health. So I just want to know if there's any thoughts about how to be channeling people into a more wellness preventive form of treatment instead of just medicalizing everything. Of course there's a place for medication, but there's also a place for prevention.
That's a really good point. I don't know if anybody saw former Vice President Dick Cheney on the NewsHour, I think it was 2 nights ago. He has a new book out about heart, which is interesting. And I don't mean to be disrespectful, but he obviously has an ideological perspective, and he was being reserved and polite. But he was making the point, and it's a legitimate point, that this is a very complex law that most people, I've got a PhD, I've got a master's of public health. I'm confounded by it, frankly, a lot of it. It's a 900-page document, the law, and then implementing something like this. So there's that, the complexity of it, and then mental health is a different animal. And in terms of untreated or an unknown quantity of individuals who will be clamoring for care, that could be huge, and there's definitely not a provider base for that, I can't imagine. And, the point is really well taken. The way the Army has dealt with PTSD, chronic pain, for example, is to use heavy addictive opioid substances, and they now have one of the highest suicide rates they've ever had in the Army. it's a real problem if you treat things exclusively pharmaceutically. I mean, better living through chemistry, amen. I had a parent with idiopathic polydipsia. Idiopathic means we don't have a freaking clue. And polydipsia means you drink water forever. She had 2 heart attacks from drinking water. I mean, it's amazing. And then finally we found, my sister was in medical school, we finally found the expert in the United States on idiopathic polydipsia. There was such a person. He recommended an off-label use for an anti-anxiolytic drug, an anti-anxiety drug. The next day, she wasn't drinking water. So there's a place, like you say, for these things, but there is a radical opportunity for abuse. I mean, much more abused than any illicit drug in the United States are prescribed drugs. There's even a term in the youngster world of farming, which is putting a bowl of your parents' pharmaceuticals. They all get together, they put random drugs in a fish bowl, and they just take whatever they want. It's called farming. So abuse of prescription drugs is huge, and there's a real opportunity for the pharmaceutical companies here if this is not addressed. So that's a really interesting point. And there's a lot of these potential unseens that are going to emerge in the next 2, 3, 4, 5 years.
So there are actually a couple of things in California that is not related to the ACA that's happening around mental health. One, I preface it by saying I think it's going to be a problem, and access to mental health services is definitely going to be a problem. But Proposition 63 passed several years ago that taxes millionaires for a mental health fund, and part of that money is going to the county mental health departments to provide services. Part of it has funded community organizations to provide prevention and early intervention services. So 5 different population groups, the Asian Pacific Islanders, African Americans, Latinos, LGBTQ, who am I missing? Latinos, Native Americans, thank you, have each put out a report on what is on a community level, what is working in their community for prevention and early intervention work. And the State Department of Public Health has about $45 million set aside to fund those activities. Medi-Cal, so in our state budget this year, it expanded mental health services in our Medi-Cal program. Before, mental health services was completely carved out, so you got your health care services from your health plan, and then if you needed mental health, you were referred to your county public health, your county mental health departments. Now there is more integration, and the health plans are required to provide some type of mental health services, so there's an expansion in our Medi-Cal program. The last thing I would say is that Mary Beth's question about the role of public health is coverage for health services was this big thing that was looming over us that we kind of had to get out of the way. Just like, okay, get people insurance, right? How well that actually gets people healthy, we just had to do it. And I actually think that having these coverage expansions opens up the opportunity for actual public health work, and the upstream approach, which addresses early prevention and mental health, when you have the safe sidewalks and the active living environments and healthy housing and all of those things as they co-benefits that I talk about. So I'm hoping that we have now gotten this mammoth task out of the way in the health field, and we can now concentrate efforts more on our upstream public health work.